thank you to Medivance and to the Joint Commission for inviting me. I talk normally about measurement-based care or a recovery-oriented system of care or cognitive dysfunction in substance abuse or schizophrenia or cognitive remediation. So when James asked me, well, we'd like you to speak alongside the Joint Commission, I said, yes, of course, it will probably be about outcomes, it will probably be about measurements, something that is that I know something about. And then a week ago he says, no, it's about building a national brand. He said, so I told him, I said, you know, I have no idea how to do that. He said, no, you are a national brand. So let me start off with that premise and you make your mind up as to whether I've been able to do justice to what he's wrote me into. So how did we, first of all, there was no master plan. There was no 5-year plan. There was no, there was no plan to say so many beds by such and such date and so many people by such and such. That doesn't mean that we weren't organized, that we didn't have a vision, that we were not strategic and we were not tactical, and that we didn't take advantage of certain things or opportunities that were there. So I've divided my talk into 3 parts. The first part is defining what is a brand. And so I've taken some slides from other people because I'm not an expert in this area, so that we learn what a brand is really, really quickly. And then secondly, I want to tell you what we did. And I just want to share with you what happened. How did we grow from 6 beds, which were an outpatient or an IOP of 500 square feet, to now having almost 2,000 people and as our wonderful employees, and still managing to keep that small facility feeling. How do you do that? How do you stop becoming detached, and what do you do? So let's see. So before I go on to the brand issue, these are national trends that are there. It's a busy slide, but this is not just about behavioral health. What is happening is there is pressure in every single sphere on going towards outpatients, going towards efficiency and measurement and outcomes. This is really important for us because we can't do the things we did even 2 years ago, forget 4 years ago. It's moving really fast, and people are saying, are we getting value for money? They're going to be looking at, if those of you that are not private pay alone, a show of hands that people that are dependent on either third-party payers, like private insurance, some of you are at least, and then either county or Medicare, Medicaid funded. If you have an external payer, and I think private pay also is going to catch up quite soon, you need to have some metrics that you need to be guided by, and things are changing. So building your brand, and this applies to all of us. And I'm going to go through some generic slides of this. What do you do in terms of building your brand? So let's start with some fundamentals. A brand is not your logo. You have this wonderful logo that your agency dreamt up and charged you an arm and a leg for. But unlike agencies, we dreamt up ours overnight somewhere many years ago. A brand is not an identity. A brand is also not your product or your service. Often it is mistaken to be a product or your service. But a brand is important because as you grow, this is going to be important. It's not your mission statement. It is, or your promise or the value base that you provide. Your brand is not advertising. So what exactly is it? It's that gut feeling that comes when you talk about that person or that product. A brand is also not what you say it is. A brand is what they say it is. And I think this is important for those of you in leadership positions. We make the mistake of thinking we know what our brand is. We don't actually know. We need to find out what our brand is. Because it is important as you develop to find out what exactly is your brand. People are making a lot of decisions every day, whether to come into treatment, whether to stay in treatment, depending on these decisions rather than logic. And you find that that's important. It says here in the slide, there are hundreds of cameras. How do you decide? Are you going to buy a Nikon? Are you going to buy a Canon or a Minolta or a Pentax? How do you make these decisions? How do people make decisions about coming into treatment? This is an important issue. They need to be able to trust you. They need to be able to make sure that you're reliable, that there is a degree of trust. And you need to build that up in the community that you're part of. A charismatic brand is any product or organization that people believe in. And everybody can get there. It doesn't have to be the Apples and the Nikes and the Coca-Colas of the world. Okay, 3 things, and then I'll move on to something that's more relevant to us, okay, and get away from James. So, first, let's differentiate. You have to differentiate. If you're offering the same product as the person down the street, there is nothing to distinguish your brand. Unless you just want to get your BFFs into treatment, that's fine. But you're not going to be able to fill all those beds, are you? With those people? No. You might think they just like you on Facebook all the time, but that's because you can see who likes you on Facebook. Are they really your friends? Time will tell, huh? Okay. What's your brand personality? What is the personality of your brand? And these are the characteristics that are there in terms of the uniqueness. What is unique about your facility? What is unique about your department? What is unique about what you do? And I think that's important at different levels. And you have to be consistent. You have to be consistent, you have to be authentic, and you have to stand up for what you believe in. And sometimes you will get shot down because you're standing up for what you believe in. And it might make you unpopular. Because if you don't define what your brand is, somebody else will. And I think it comes to our specialty as well. If we don't define our standards, somebody else will. And those of us that depend on third-party players, they will define the standards for us unless we define our own standards. So that's what is important. The second point. The first point was differentiate. Second point is focus. So you need to decide what your focus is going to be. And I'll show you what we did at Sovereign. And it wasn't, this was because we had certain areas we thought we had expertise in, and we just followed that. So what is your focus? And this is how some people from outside might see you, that you can't be everything to everybody. And so you've got to decide where you're going to pitch your tent, how you're going to do this. Who are you, what do you do, and why does it matter? So, this word is pronounced Porsche, by the way, just so that you know. The owner was Ferdinand, the man who started this company. His name, his family name was Porsche, P-O, almost pronounced P-O-R-S-H-A. And he, so when he started this company, but we put this up there to give you this sense of, when you talk about Porsche as a car, what do you think of? The 911, it's a sports car. This is not something you take the kids to school in, right? You might, but it's not the most logical thing to do. But as the most trendy dad, maybe. However, when they do this, are they losing focus? Are you going to buy an SUV from Porsche? What is Porsche known for? That's why their SUV sales are what they are. How many Porsche SUVs do you see? There is, when Bentley starts doing this, thankfully Aston Martin hasn't done it as yet. So, and that'll be the day. Third thing, how do you build your brand? You share. You share. Things are different in today's world, and I'll talk a little bit about what happened previously and how expectations are different in terms of features and the benefits and experience and identification. So the evolution of brand building has been quite interesting. In the past, you say, we are great, everybody accepts it, because you have a lot of money to advertise on TV. It doesn't matter. Now somebody with a startup and enough people on social media will come and destroy you. So not negatively, but they might have more power than you, than the millions you're spending on television. So in the old days, you would send messages across, whether it's television, advertising, whatever else. Today, you need to have conversations. You need to have conversations with your referents. You need to have conversations with the regulators. It's much more collaborative, and that's what all these things talk about. Before, it used to be a transaction. Today, it's about relationships. How do you build those relationships? And your brand needs to tell your story, whatever that story is. So, and it used to be, the people would ask, when are we starting our next campaign? Well, we need to start talking about, when are we going to commit? This used to be what it was all about in the past. The campaigns and bombarding people with things. And then, now we need to say, okay, let's have a coherent story. Let us help people and let them understand. Social media posts, for example, 80% of your posts should be educational, and then 20% of your posts should be about your facility or advertise, whatever it is. If you just dump testimonial upon testimonial and just about your people are not going to read it, or they're just going to go away. So they need to find value in what you're doing. One of the most famous brands in the world. But you associate that music, and then when they have that upbeat music, they have young people drinking a colored drink that they have managed to sell to the rest of the world, which raises your blood sugar. Yes. This is the ultimate in marketing, isn't it? Only second to cats taking Prozac. Okay. The second here. They immediately, in terms of Nike, they linked it with the goddess of victory. Nike makes you victorious. So associations and what you do, how you do these things. Now, storytelling is an important piece, and that's what you need to do in terms of building that brand. And you have no control. So forget about controlling that message and all the stuff that agencies or other people would tell you. And we've never ever hired an agency to tell us any of this. And I'm just telling you what we find. So brand communication is not a monologue anymore, it's a dialogue. You're talking to people on social media, you're talking to people at meetings, you're getting feedback. And then, obviously, social media is a big piece today. So you were shouting loudly in the past, and you thought the louder you shout, the better it is. However, how much of TV time you can buy, but it doesn't really matter. It matters as to how you can have a meaningful exchange with people within the community that you are. So, as you can see, it becomes anonymous. There are lots and lots of messages. If we are a facilitator, if you help people, then you will be known as somebody that becomes an influencer. Not necessarily in the LinkedIn sense, but an influencer within that community that you are. How do you build that brand yourself? So, and then also follow what people call you. Who calls you? How many trolls do you have, and how many people don't really like you? Find out. So, and then this is what the whole world can see about you. Also, organize your messages. Be consistent about what you represent. What do you stand for? It doesn't have to be, you don't have to be the CEO of an organization. It could be just your department. What is your department doing? What is the message it's sending out to the rest of the people? Okay, you get committed followers. People that are, if you do good treatment, for every bad Yelp review that you get, that we are petrified of each time because we lose admissions and whatever else, you will get the good reviews on the different sites. And I think that the things we cannot control anymore because the world has become flat. It's no longer people who just have the money that can control the message. Okay. That's the background about stuff I don't know. Let me tell you things that we have done. So, things that we have done. So this is stuff, whether I know it or not, we've done it, so I can just tell you. So, sovereign way. This is, we treat mental health as well as substance abuse and are very clinically focused. In terms of our programs, and these are the types of programs that we have, and the patients that we serve. We differentiate it. So I'm going on from the theoretical stuff we talked about into what we have done, and I'm trying to fit in the categories in an unconscious or other conscious way. You figure it out. We are dually licensed. We decided very early on when we had 6 beds that we were going to go after the mental health piece, and we felt comfortable doing that we were not a rehab center, that we would do behavioral health. And I'll show you why in a moment. So we are, where there is a license, and interestingly, Texas has no licensing for residential there are no regs in Texas for residential mental health, just so that you know. I spent 4 months arguing with the authorities, and the only way we can do this is getting Joint Commission accreditation for mental health. But even then, whether it's going to be dodgy or not, I still don't know with the payers. But wherever there is, for example, in Florida with ACA, in California with community care licensing, these are mental health licenses. So we decided that we would go, we would not only have from DHCS or ADP, its predecessor, we would have the licenses. And there is a strategic reason, plus we felt comfortable. In 2009, the Joint Commission surveyor walked in and said, "You're sure you want to have accreditation for this 500 square foot IP? We haven't actually done this anywhere in the country. Most people don't go for this size that you have." So he said, "You want to spend close to $10,000 for this." We thought we were not going to go for CARF, we're not going to go for any other types of accreditation. So from the time we were little, we went for Joint Commission accreditation. That's not why I'm here. I'm here to talk about the brand. But we decided, even when we were small, that we would go for the standards that would give us credibility. We would go for the standards that would allow us to grow and be guided by. We didn't know everything. We learned along the way. We made our mistakes. We put our hands up. And then we decided that we would also have a broad continuum of care. And then as for a number of years, we grew in one location. And then decided that we need to be closer to the people we serve. And so getting away from this destination rehab business and not expand for the sake of expanding, but strategically thinking, where can we be in terms of people, and where is the need for such services? We looked at our data, and then we were guided by the data. Always be guided by the data. Opinions do not matter, and everybody will give you their opinion. Data do not lie. Look at the data. Look at where your people are coming from. Look at where the admissions are coming from. Look at errors that are happening. It is the data that needs to guide you, whatever you do. This is an important slide, data from SAMHSA in their report, and it tells you what this is. Everybody was fighting in. So this is substance abuse. So as you can see, these are people with the substance abuse disorder. These are people with dual diagnosis. And this is the mental health piece. Now tell me. So this is Sovereign's ballpark. And we have little or nobody apart from people that are doing this, people that are running board and cares. 40% of our people have mental health issues today in terms of our population. I'm saying this, will you be our competitor? Welcome. We want more people to treat people with mental health. Look at the size of, if you just look at market size, if nothing else, look at the market size of this versus this. Everybody's fighting in this ballpark. For us, if you look at this space, there's nobody, right? And then people say that they are treating dual diagnosis. Do they really have the capability of treating dual diagnosis when you don't have mental health expertise? This is something you got to ask. We see this because our largest referrals are from hospitals. Second largest, 50% of our referrals step down from hospitals. Second largest are from other treatment centers. Why? It's the enthusiastic admission person. Oh yeah, you got schizophrenia with bipolar. Come on in. And the clinician sees them next day, oops, this is a sovereign patient. Okay. So what do you do in terms of how does, and again, as I said, it represents 2/3 of what we do in terms of our patient population. And we just need to, we don't consider ourselves to be an addiction facility. Addiction is a carve-out. We are a behavioral health system of care that is nationwide now. And we think that it is important. I wrote several pieces on the LA Times, on the editorial pieces that were there, where we have to treat the mental health component if you're going to get better outcomes. Okay, here we go. So we started off in San Clemente, as I said, with 6 beds in a transitional living with 500 square feet, 2009, end of 2009 or so. And then today we've got, in between there and Irvine, we've got about 226 beds at different levels of care, from detox to thing. And we're doing addiction and mental health. We're serving people suffering from substance use disorders, mental health, eating disorders, chronic pain, and some cognitive problems. And then this is our current situation nationwide in terms of where we are, what we are doing. So this is as of now, El Paso actually has 60 beds, but it's neither here nor there. The number of beds don't actually count. And I'll talk to you about the challenges of doing this and how do you do this without venture capital? How do you do this without debt? How do you do this? Why did we not want, we had Goldman Sachs come 3 times to us. We didn't want to lose the mission that we had going forward. We didn't want somebody also who owns a waste management company telling us how we should be treating patients. And it happens because we did not want to be an aggregator. What you have now is aggregator, people buying things wherever it's possible, and you will see what we've done at Sovereign is different. We have people buying things, they're aggregators. They will then do cost cutting, centralize services, lay people off, and then they will sell it off for 4 or 5 times what they've made. That's the business model of venture capital. Cannot blame them. That's what they do. Once you decide to go down that path, you're prepared for all of that. And they do it well. And we've had many come this way. And we said, okay, let us go at least to the point where we can be at a place where we can have we have the power to be able to negotiate what we want, and can we do this with debt funding? So far, we managed to do it without debt funding. And unfortunately, we don't have 10 senior vice presidents, and the CEO comes and he's also talking to the Joint Commission about regulatory issues and is interested in quality rather than sitting in meetings all day. So we have a fairly flat structure. And also people have great ideas at the grassroots. So for those of you in senior management, as you start growing, you start losing touch with the people that made things happen. I think it's really, really important to walk through the facilities, to talk to the patients. If somebody cancels an appointment or stuck in the freeway, as happens sometimes, we have one of our sites is locally in San Clemente, and our corporate office is there. I'm down, sitting with the patients, ask, why did you come to Sovereign? What happened? Have you done, how are your one-to-ones? How are your groups? I'm talking to our clinical concierge who are responsible for continuing care, talking to the patient advocates who are looking after these patients and saying, well, has the family call been done? Is the family coming for the family group? If not, why not? Why aren't we doing telemedicine or telehealth with the family if the family cannot come? They know I'm going to ask that question. And the same way, you have to have the leaders walk that walk. That's how you build quality in a program. And they know I'm going to ask those questions one way or the other. And there's a community group at every site, every week. And I get the minutes of this. And that's the group that we never have to shepherd patients to come in. They queue up right until the road so that they can attend the community group. Why? Because this is where they give us feedback, that we hear from them what we're doing right, what we're doing wrong. And there are lots of compliments for therapists, for techs, for house managers, as we call them differently in different states. We need to know who's doing well, who's not doing well. As you grow, you will lose touch with people. And it's really important that you are aware. And these are our sites in development in Murfreesboro, in Ashland, Pennsylvania, in Ludlow. We have just, actually, we've got Joint Commission, I don't know what it's called, it's approval of some sort before we've got licensing. That's what they required over there. And then once we get licensing in Ludlow, in Springfield in Massachusetts, we'll have the Joint Commission come out again. So these are, this is the state of, the current state, and let's see if we can continue along these lines. Now, as you can see, I'm not talking about number of beds. I don't care about the number of beds. I care about being closer to the patients, the people that we serve. That's important for us, because people are coming from the Northeast, flying all the way to California. Why? Why not be closer to your family so that we can have the family participate in the family program over the weekend? So that's what we wanted to do. So this is what sets you apart. And for each of you, you will have some kind of uniqueness. Look at it, figure out what it is, and then I put down here what we think sets us apart. And what do we, and the fact that we are Joint Commission accredited. We are pretty proud that we are Joint Commission accredited at every single site. And as we get this up. Growth is a function of what we do. It has been, as I said, there hasn't been a plan for that growth. It's been almost automatic, and I don't think you can keep up that pace. You need to steady up. It's kind of climbing to 35,000 feet, and if you keep going up, the air becomes even more rare. So you've got to level off at some point, or you run out of oxygen with a full tank, and that's dangerous. So for 3 years, we have been in the Inc. 500, 5,000 list, and last year we've been in the top 11% in the country in terms of growth and the speed of growth. And that's really credit to the people that work at Sovereign, and not necessarily to the management, because they're very invested. Hire people for the why. Hire people because they believe in what you are doing. They believe in your mission. The how and the what, you can teach them, unless you're hiring an expert. If you're hiring an MD, that's a different thing. But even with an MD that you're hiring, hire people for the why, so that they believe. So I sound like a cult leader now, I'm sorry, but it's, you really, really need to do this. Because if you have people that believe in what you're doing, then they're going to stay with you, they're going to, and they know that they have a purpose. If they want a paycheck, I have paid people to go away. I said, you're really not a great fit for us. Let me pay you, and let me recommend you'll be a great fit somewhere else. I'll give you a great reference, go away. Because they're not a great fit. And this is really important, because they need to know that passion drives you. that they need to know that your value system is important for you as senior management. If you've been headhunted to do this and you as the person that is there, tomorrow you're going to be a CEO somewhere else, then this is meaningless for you. It doesn't matter. Because you're here for this paycheck and then you're going to get another 20% bump and some headhunting firm is going to take you elsewhere. But if you're building things up and you're passionate about what you do, then hire people in your image. Hire people that they don't have to be in recovery. And this is my beef with the industry, that if I had a heart attack, I'd go to the best cardiologist, not a heart attack survivor. Does it not make sense to you? Yes? So, and no disrespect to anybody else. So my point is, search out the people that are best in the job that you can afford to hire them for the why, the how and the what I can teach them. Jessica knows about Salesforce, about BOBs and all that. She was doing some marketing stuff before I brought her into all of these things. But we can teach people things. We can train people if they have the right attitude. I'm sorry I belabored that, but it's important because when things get tough, you want people to be holding hands. And it will get tough at some point because we are in a very unpredictable business of behavioral health. You're not doing outpatient urgent care. So even how did we do it? These are the 4 Ps that we're guided by. Please notice, I did not put patients first in that slide. Everybody says, oh, patient is first. For us, patients are not first. It is people who are first for us. If you take care of your people, they will take care of the patients. You can call them clients, patients, that's an individual preference. So, and then the process. If you don't have process, you are doomed. You can manage 20 beds, 30 beds, 40 beds. What would you do after that? Because when you're small, it's all hands on deck, right? You're all friends, everybody's working and you're doing things together, you're picking up people from the airport, it's great. As you start growing, your phone is constantly buzzing. I get 2 calls a day, and then both of them are from my mother. So you have got to make sure you've got processes in place, right? So this is really important for us. People, if you take care of people, they will do this. And patients, processes, and then you need to be profitable because if there is no future for people, if they cannot grow within your organization, why are they there? It's a static organization. And for nonprofits, again, the question is you don't call it profit. The IRS calls us for profit. Our bank manager thinks we are a nonprofit. But irrespective, the question is you need to grow, however you term it. And I think these are important, have been important for us at least. I don't know how you view it. But also developing a corporate structure that's robust, a structure that allows you to sustain itself. We call it the sovereign franchise model. We don't have any franchises. But this is the model that has allowed us to grow and grow exponentially quickly enough. What we've decided to do is that we will keep certain functions centrally and we will have other functions dealt with at the local level. So shared mission, shared treatment philosophy, common treatment programs that will, say, Fort Myers they do the same training. I was in Chandler yesterday. We have a women-only treatment program there that deals with really terrible, the patients there have terrible trauma that has happened, both in mental health and addiction. And they were part of the training, global training we call it. And every single site, the clinicians were being trained for 2 hours. And the training was done centrally from Central Elementary. So those are the kind of things. The quality is maintained, and that's the commonality. Staffing, HR. So those are the kind of things. These are the shared services that we have. This may or may not be the right model, but this is what we do currently. This is how it's allowed us to scale up. Because if you want to scale up, there are certain things. Learning management system. It's really, really important. How can we ensure that we are compliant with Joint Commission if infection control is out of control? No? So That's the issue. But people need to know that hand washing is required. They need to know also that medication management, they need to learn all of these things. If you're one site, it doesn't matter. Even if you're 3 sites, it starts mattering. So you need to have systems, and they don't have to be expensive. There are fairly inexpensive systems that are there. And this is the bee in my bonnet in terms of outcomes. As you probably know, the Joint Commission has a standard from the 1st of January to 2018 about measurement-based care. And we've been talking about measurement-based care for a while and have been walking that walk for the past 2.5, 3 years now. Dr. Veena Kumari, our Chief Scientific Officer, has been collecting data on the eBasis 24, and I suggest that you look at it, or if you contact us, we'd be happy to share that with you. The question then is, everybody, including the Joint Commission and our payers, will be requiring us to look at outcomes. And outcomes are not about what is your relapse rate, which is a ridiculous question. I have no clue and have no control over what will happen to a patient when they have discharged from our facilities. They could go to a loving, caring family or friends that will take care of them, ensure that they are attending meetings or they're compliant with their medication if they're mental health patients, for example. And they could be well, or they could go into a sober living and then onto a frat house. So, and you treated them both with the same degree of competence. How does your treatment reflect whether somebody relapsed or doesn't relapse? We have the wrong measure that we're looking at. When people ask you what is your relapse rate, you can just say, seriously, that's the question you want to ask me about the competence of my program? It shows how ignorant they are about what they need to measure. What you need to measure is this. You need to measure how good is your treatment program. You need to measure how engaging are your therapists, what treatment alliance they have been able to build with the patients. And there are simple scales that will allow you to do that. It doesn't take time. It doesn't take time. It takes very little extra resources, and you can do this and you can incorporate this into the routine clinical practice, or if you have a compliance department, they can run this alongside. But even with smaller programs, you can incorporate this. So measurement-based care is something we've been doing for a while. And we do an extended assessment. And that's because we are interested in the science of it, and you don't have to do all of this. But if you do, for example, the PHQ-9, which we do for people with depression, it allows us then to argue with the case managers and the insurance companies in terms of having a metric. As you can see, I'm really driven by data. I'm driven by numbers. Because, the patient's getting better. Well, and the case manager on the other side of your UR, for those of you that have to do UR, utilization review, says, no, he has been in treatment for 2 weeks. He should be now dropping to PHP, IOP. Some of you are smiling here. I can see I have some friends, at least in the front row. So if you tell them, no, the PHQ score is this, they don't have, unless you're lying or you can fax it to them, they don't have a leg to stand on. i.e., you are able to increase your income, paradoxically, by using measurement-based care. Nobody actually thought about that. And we didn't think about it. We wanted to enhance quality, and we're foolish at Sovereign, so anything to do that so that a higher level of care. Because we get the most difficult patients. We get really difficult patients, and it's important as well. Some patients don't improve. And there's a different talk that I give on measurement-based care. And I show there that there is a percentage of patients that don't improve, and the therapist thinks that they improve. And you see, therapists want to be successful. Their ideas, patient is improving, to whatever extent they're improving, because I am the therapist, I am helping the patient. The fact that the patient has not improved, it doesn't matter. It could be that the therapist is useless. It's a possibility. The patient is on the wrong meds. That's a possibility. The patient has treatment-resistant depression, needs something more, ECT, TMS, whatever it is. That's Third possibility, it could be the illness itself. It could be the circumstances that they are in. They're in the wrong circumstances. They have such recalcitrant problems that they cannot, it doesn't matter what therapy they receive at this point. But let's identify those non-responders at least and stop wasting time. But that's a different talk. This is something I was talking to 250 psychiatrists and addiction specialists at the New York Society of Addiction Medicine on Saturday. And a fairly lively debate about how you can turn this around into a positive rather than this being an albatross around your neck. Measurement-based care is something that we need to all incorporate into our daily practices. And it's possible to do that because where are the standards? Today's in surgery, we got parity in behavioral health, but ask yourself, are we at par with surgery? Are we at par with OBGYN? As far as behavioral health, as far as addiction treatment is concerned, where are the standards? When you send somebody to treatment center A versus treatment center B, how are you comparing if somebody has got better in one or the other? A surgeon has infection rates. A surgeon has how many days the person was in hospital post-treatment. You have metrics right across. We have no metrics. It's what you say, how good you are. That cannot happen. Unless we set the standards, somebody else will. And I think that's the problem that you have. And if they set the standards, you have a problem. So I think we need to wake up. And NATAP and all these people, they're completely useless. They don't even know what they're talking about. So, yeah, I'm sorry, but it's blind leading the blind. So if they think that having a group of friends on your board is what it's about, we are not members of NATAP anymore because we are not just addiction. But this is not about bashing them. This is about saying we need to be measurement based. We need to have standards for ourselves. Okay, institutional development, I'll finish soon. So I'll give you the slides so you don't have to copy anything or even read in case you're asleep. So what do we want to do? We want to make sure that we use technology. That's the other thing that we've done. We've used technology extensively. We have this patient information management system, and we had the clinicians, we dragged the clinicians kicking and screaming to use it. We built this in-house. The point is this. You have your EMR, whatever you're using, Kipu, Best Notes, Sigmund, whatever. You have your EMR or your EHR, and then you have a huge amount of data outside of all of that. You have the end of shift reports, you have reports from different people, you have your med logs, 1,000 documents, and then the emails that drive you completely crazy all the time. And you think, whoa, what is this? So what we did was we said, we want an end to this email nightmare. So, and when you have 2,000 people, each one sends like 10 emails a day, and then you can see, iPhone says no more, no more. So what we did was we said, we want a portal that has all this information right from the beginning to the end that is not covered by our EHR. So that's what I'll show you in a moment. Centralized other resources are hiring HR and having your employees engaged, and I think this is really important as you're talking about. Make sure that they are pointing in the right direction and they are engaged with your mission, with what you stand for, in your value system, what you want to do. Quality improvement program, really, really important. People pay lip service to this, and sorry, the slide is not that clear. Who's on your governing board? The senior management needs to be invested in quality. This is really, really important. Yeah, you can't pay lip service to it. Whether you get, some of you have accreditation, some of you may not have accreditation. That is irrespective. You need to be invested because if you don't show that interest in quality, nobody else will. It has to come from the top. In terms of innovation, we have used technology, and we're proud that we're able to do all of this. And we've used a technology known as a method known as Scrum, which I've led a software development company for quite a while. And we adopted that from software development. And that's why, we've looked at being disruptors in the space. How do you go from one to the other? This is from the Harvard Business Review, and these two people were talking about, two Japanese academics actually, talked about the inefficiencies we had on the assembly line. And this led to Toyota changing the way they did things, changing the way they did their assembly lines, and led to enormous amount of productivity, and led to the development of Scrum methodology. And you can look that up in terms of what Scrum is. And we are looking at, we are doing things. Our legal department, for example, work on a Scrum method now. And every single contract that comes in, every single NDA that comes in, and we are able to process that really quickly. And we have 3 teams, a legal team in Pompano Beach, a legal team in San Clemente, and a legal team in New Delhi. And they all work at the same, together, the same pace. This patient information management system, a couple of slides on this, in terms of this is where we keep all that information. And everybody from the house manager right up till the CEO has access to this. This is where we keep all our information. And these are the unique features of this system, where we integrate this with all our sales, with all the information. This is a one-stop shop. So it's also integrated with our GPS system and our fleet management system. So if a concerned parent calls us from New Jersey at 9:30 at night and says, in California time, and says, I've sent my daughter to Sovereign, this call will go to our global contact desk, and it will probably be in India. And that person can look up 2 things. 1, all the details of this person, and without confirming or denying at this point, can also look up where our car is, where the driver is, and can say, well, this person, our driver, is by belt number 3 at Orange County Airport, and can also they're also monitoring the flight at the same time. That level of customer service, that level of ability to be able to do that allows you to connect with the family. Because it could be, this is what I tell our people, it could be my loved one who's in treatment. Is it okay for them to sleep on that lumpy bed? Is it okay for my son or daughter to eat that food? If it's okay, then that's fine. If not, then you cannot have that for that patient. Because you can never have an employee handbook that is big enough to deal with all circumstances. And this is what I tell them each time. Think, if my family member, if I'm going to be angry with you, if my family member was in that position and you're okay with it, then that's fine. So I think that's how we guide people. What does the Ritz-Carlton do? They empower people at the lower level to be able to provide that level of customer service. So we're not saying that you need to go overboard, but how can we use technology to make these things happen? And the unique feature, as I said, 1 patient, 1 record, and then right from intake, our BPS goes into it, our intake goes into it. All of this, our UR people can pull up. If somebody says something, just on her smartphone can pick this up and say, whose VOB, how many rejected VOBs did we have today? We can pick it up now. So that's how it allows us to figure, and then we can refer out to you. We can say, we are not using this VOB for whatever reason, or it's a network, or it's only valid in Arizona, for example. So we can then refer out to people accordingly. So and these are people that can log into PIMS, and this is entirely homegrown. And so we can collaborate across. It has decreased the number of emails dramatically. And we're hoping that as we mature this product, we can share it with the community. And then bed booking. So if you look at this, and then centralize appointments. Because people will book people for one-to-one, they're also booked by the nurses for the doctor at the same time, also for EMDR, and for neurofeedback at the same time, and for cognitive testing. Go figure. So the person in, Scott Langer sitting in Boston can figure out if we have a bed in a house in San Clemente, and can guide the patient into that bed. So we can say, well, in this house over here, what happens is if these are beds that are available in Bonanza House, for example, it says mental health. These are beds available. These are beds that are blocked for people that are in transit, and these are beds that are occupied. So, and then whenever you have an AMA, ACA, whatever it is, or you have a transfer or discharge, this bed becomes green. So you can reserve a bed, and you can know exactly. You don't have to call. Hey, do you have a detox bed? Sounds familiar? So I know if you have a detox bed, and everybody knows. When you have 80 people who are taking calls in Pompano, virtually in San Clemente, and in India, who's going to call whom? So that's what you need to do to be able to figure this out. Anyway, let me just go through. And UR authorization. The clinician will say, oh, when was the last date of look it up in PIMS. It's all there. Okay, let me skip over these things so that. And then lastly, this is the app we have for our drivers or chauffeurs, where we can figure out exactly where they are, who they're receiving. And somebody in Fort Myers, we can then pick that up immediately over here. So that allows us to be efficient, who's picked up, who's not, who's got appointments. So it's a hybrid of a limo service, essentially. And then SMS alerts go out accordingly. So let me finish up. Okay. And what are the innovations in the pipeline? We are looking at an interactive portal so that referring people have access to as much information as they want, in terms of saying, okay, where can we refer these patients to? Again, collaborative, giving information and allowing them appointment scheduling in terms of mobile apps. And we're building our own EMR. We're saying, okay, we already have this. Why are we dependent on somebody else? Why not have your own EMR? And then our lead generation system. We have been building that and looking at, you want to pay so much to Salesforce? Because Salesforce called me and said, well, we have this wonderful thing and all the stuff you don't do in Salesforce and your EHR, you can have it there. I said, do you want us as a consultant to you? So, because we've done this already. So, one-to-one, just showing you some data. This is data that shows us you have to objectively measure therapeutic alliance. This is really important for us because, and there are scales to measure it and quite quickly. So you can, these are therapists, and then this is a scale here. I'm just showing you data that shows that this is the higher the therapeutic alliance, on the scale of 50, the better the therapist is, and the better your outcome is. So you can see who sucks at treatment, and then give them a good reference to another center, and then why? And this is my last slide. Why does measurement-based care, apart from the increased days you may get, and we do get, why is it important? You look at where is the evidence base for it, and here is the evidence base for it, that people who follow measurement-based care, you have better response to treatment, you have increased remission, you have longer duration of stay. Just these three things alone make it worthwhile. And I'm really glad that the Joint Commission has now incorporated this into their standards, and we worked pretty hard with and closely with Tracy Collender before she moved on in terms of incorporating measurement-based care. And I think this will help us improve the standards in behavioral health. So he wanted me to talk about something else, and I obviously ended up talking about how you can improve therapeutic alliance measurement-based care. So thank you very much.